In the interim, we go on to our next speaker, Dr. V.R. Saravanan, who's the Chief of Retina and Vitreous Services from the Aravind Eye Care Systems, Coimbatore. And he's going to talk on another challenging talk, relaxing retinectomy in macular hole surgery. Saravanan, I'm sorry I didn't give you time to...
Thank you, ma'am. Thank you, ma'am. I'll just share my screen. My slides visible now? Sorry.
Yes, yes.
Okay. So I had skipped the pathology part because I thought Bagulani madam will be talking about it anyway. But anyway, so these were the terms initially used for myopic traction maculopathy, but now the commonly accepted term is myopic traction maculopathy. And I'm just showing some few photographs of early and late here. This is one patient who's got you can see the thicker and contracted posterior skytic vitreous causing the right eye. You don't see any tractional effect, but in the left eye you can see the inner layer is lifted up, showing the early tractional effect. And here in the next patient, you can see that the inner layers are slightly getting pulled up, causing early schisis in the left eye, more prominent in the left eye, and also in the right eye in the nasal quadrant. So again, this is one more case showing the retinal schisis much more prominently, and you can have a secondary CNM in this particular patient. And this is the last stage of the disease where you can get either inner lamellar holes or a full thickness macular hole with a posterior pole detachment. So I'll be talking about two cases of myopic macular holes which did not close with the primary surgery and how we went about managing them. So because of the high degree of the staphyloma and the high degree of myopia, the staphyloma is outgrowth of the scleral layers. And apart from that, you have the thickening and stiffening of the skytic vitreous, internal limiting membrane, and also even the blood vessels cause some amount of traction. All these leads to a sort of a stiffer retina, which fails to bow posteriorly to conform to the curvature of the new curvature of the sclera. So what happens is when you have a secondary macular hole, this can be a problem with the successful macular hole closure. The various options have been vitrectomy, supported with macular buckles, and also plain macular buckles. All these have been proposed as a treatment for myopic macular holes. And as you can see from this one of the studies that there's almost 30% risk of failure compared to almost 2% with the routine patients. In high myopic patients, the chance of hole closure with is quite poor. We have almost 30 to 40% risk of failure in one of these studies, which showed here. So the normal globe here, I'm just showing a sort of a schematic representation, and we have a posterior bowing of the sclera because of staphyloma, and the retina does not fall backward because of the various forces which we described. You have both the anterior posterior tractional force from the vitreous and the tangential tractional force from the skytic posterior vitreous and the ILM and the blood vessels and other because of the RP migration, because of the retinal proliferation. So the ideal choice would be to support the posterior sclera with the myopic and macular buckle, or like the previous speaker, how he showed where we can push the choroid inside by through using a suprachoroidal buckle. So either of these things would be the ideal choice. But as already shown earlier, there are not very people who practice this because of various steep learning curve, and also the availability of cheaper alternatives. Like in India, we don't have a very good cheaper buckles. The easier and more successful buckles are quite expensive. So what I was trying to see use in two of my cases was I was trying to make a peripheral, rather temporal retinectomy, wide retinectomy, to allow the retina to slip. Like normally you see in a giant retinal tear, when we can have a posterior retinal slippage. So similarly, in our cases, I was trying to create an intentional retinal slippage by creating a intentional temporal GRT or a retinectomy, a large relaxing retinectomy, to allow the retina to fall back and conform to the curvature of the sclera and choroid. That's what this technique was. I just showed two cases here. This is a 54-year lady who was blind in the other eye, and she had already undergone scleral buckling surgery approximately 20 years back. And she came with a drop-in vision because of posterior pole hole and a posterior pole detachment. And the initial surgery, it was not successful. And you can, this is the preoperative OCT, and you can see the large staphyloma with elevated retina. So after the initial surgery, we could not achieve total opposition of the retina to the RP and choroid, and the sclera. So it was the
loudly or
yeah. So the hole was not closed, and the retina had not opposed to the sclera and choroid. So we had to go in for a second procedure because we could not achieve a primary success. The vision was still poor, and it was a 1/8 patient. So what I did here was, you can see in the video, as you can see here. So after removing this silicone oil, I did a tried to do ILM peel to do an inverse flap, but the ILM was very thin and I was not able to do a successful complete flap. It was coming in small bits and pieces. So I was not able to achieve a good flap to cover because initially also they had done ILM peel. It was not, only I was trying to work from the peripheral bits. I was not able to get a full flap because the retina was quite thin. The ILM also was coming in extreme pieces. And you can see the atrophy just temporal to the fovea, a large area of exposed sclera because of the atrophy. So I did a relaxing retinectomy extending from the inferior almost temporal to 12 clock hours in inferior, temporal and inferior relaxing retinectomy. And using a vertical scissors, I'm just fashioning a small small retinal flap from the peripheral edge of the peripheral relaxed retina. This is all done under PFCL. And I'm trying to create a flap with the vertical scissors here. And once the flap is fashioned, using my forceps, I'm dragging the retina under the PFCL to sort of lead it onto the posterior pole to cover the open macular hole. So here I'm doing both the relaxing retinectomy, and because I had a relaxing retinectomy, I did a small piece of designed a small piece of autograft from the peripheral edge of the RR, and then pulled it over to this to support the large macular hole. It's quite a large macular hole. I did it to support the macular hole. So after around 4 months, we did a silicone oil removal also. And this I can see that now the surgery is complete. And I did a laser and then put in silicone oil also. And this is the post SOR picture, and vision improved to 6/18. And you can see the apposition of the retina now. And you can see the graft is closing the macular hole. You cannot see the macular hole. And you can see this is the area of the laser mark. This is a 180-degree area where the retinectomy was done in temporal almost 6 clock hours from approximately 12 to 6. So a large retinectomy to allow the retina to relax and slip into the posterior staphyloma. So this is second case. Again, this patient already had undergone primary surgery, but it was not successful. And post SOR, she went in for a recurrent detachment. Initially it was successful, but post silicone oil removal, you can see the residual silicone oil bubble there. And after that, she went in for a recurrent retinal detachment. Again, the same technique, peeled off the PVR, and then trying to do ILM flap. In this case, I was able to successfully fashion and support the macular hole with a sort of an inverted multi-layered flap there. And then I'm doing this temporal retinectomy, as you can see here. And it is relaxing the whole temporal retina, starting with the inferior part. So to create a large sort of a GRT sort of effect to allow the retina to slip. So this is what I was trying to do, and we are able to successfully attach the retina and close the hole also. So I just after this, I found out a small study of around 11 cases. This is not a RD cases, but this was a myopic staphyloma with myopic holes. So here they did a sort of temporal relaxing retinectomy, but not as peripheral like I did. But they did it just outside the area of the staphyloma, but those are all in attached retina, and they were able to achieve decent success in their cases. You can see the relaxing retinectomy is done just at the outside edge of the peripheral to the edge of the posterior staphyloma. Because these were attached retina, they didn't go peripheral like in my cases. I did because it was already detached retina. Just wanted to show these two cases as a sort of a technique for attaching macular holes with the large staphylomas to allow intentional slippage by creating a giant retinal stare. I'll stop here and I'll take questions.
Amazingly terrific concept, Sharman. I don't know about others. I was stunned.